Good evening or good afternoon, everybody, and welcome to today's class, February 2026. Before we begin, everybody, please unmute yourselves and then read what is written. Everybody, let's go. 1, go.
Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that must frighten us. We ask ourselves, who am I to be binding soldiers to the public? Actually, who are you meant to be? You are a child of God. Playing small does not save the world. There's nothing enlightening about shooting at the dummy mountain. We are all meant to shine. We were born to manifest the glory of God that is within us. It's not just in some people, but it's in everyone. As we let our own light shine, we consciously give permission to do the same. As we are liberated by our own fear, our presence automatically liberates us.
As we are liberated by our presence automatically liberates us.
As we are liberated by our own fear, our presence automatically.
Thank you for reading, and I hope you personalize this information. From Marianne Williams. Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, fabulous? Actually, who are you not to be? You're a child of God. Your playing small does not serve the world. There is nothing enlightened about shrinking so that other people won't feel insecure around you. We are all meant to shine as children do. We were born to make manifest the glory of God that is within us. It is not just in some of us, it's in everybody or everyone. As we let our own light shine, we subconsciously give other people permission to do same. As we are liberated by our own fear, our presence automatically liberates others. And I hope again that you are going to take these words to heart, even as you begin your journey, and do not make passing your exam the ultimate. Make it a stepping stone. Do not make MDC. Yeah, I've passed MDC and I've achieved the greatest I could ever achieve. No. You are powerful beyond measure. Whatever you are thinking of, think beyond that. Okay? God did not bring you out of medical school to leave you stranded. Think beyond that and then be the best doctor the world is looking for. Today, I am going to begin a lecture series with you in cardiology. I have studied the trend, and I have studied not just in Ghana, but in, among various examination bodies, and I've seen that it follows a way. Okay, so I just want to apply that and then make sure that I'm preparing you for exam and also to actually diagnose conditions when you meet patients. So this positive affirmation was just by the way. If possible, I will bring before every lecture, you would have to reaffirm your ability. Now listen, I'm going to skip this slide and come here. I know I have said this in previous videos, but this is going to begin a new series of videos you are going to see. I'm going to tell you that number one, number two, number three, read what you see. One, go.
Your exam tests your ability to memorize some concepts, understand most of the things you've memorized, teach what you claim you have understood.
Understand most of the things you have memorized, teach what you claim to have understood.
These are the three principles. Do not demonize rogue memorization in medical school. It doesn't work. Do not demonize rogue memorization in medical school. It doesn't work. There are some concepts you are required to memorize and to produce them when they are required of you. Your exam tests your ability to memorize some concepts and then understand most of the things you've memorized. And you should be able to teach most of the things you claim to have understood. We test your ability to memorize. You should be able to tell that, for example, the cardiac axis is from -30 to +90 degrees. And when that question is asked, you should be able to shade, not because you understood anything, but because you memorized. You should be able to tell that at birth, BCG vaccine, oral polio 0, hepatitis B vaccine, which will be introduced in 2025 December, and then pentavalent, rota, OPV1, pneumococcal, pentavalent, rota, OPV2, pneumococcal are given when the child is 6 weeks, 10 weeks. You ought to have memorized it. And immunization would always be tested in MCQ, in your OSCE, unmanned OSCE. You will be able to produce that because you memorized. The tool we will use in memorization most of the times, as many of you are aware, is mnemonic. This is the tool we are going to use. You should be able to understand most of the things you have memorized. And this is tested both in MCQ, in the OSCEs, so that if I give you a history station, if you are preparing for your OSCE, I give you a history station, or don't let us go to OSCE yet. In the exam, if I told you that a man presented with an ascending paralysis after a 3-week history of diarrhea, which was mucoid, you should be able to shade the answer. If I'm asking for the most likely diagnosis, you should be able to shade Guillain-Barré syndrome. Not because you memorized per se, because you understood the question and you knew what was wrong with the patient. You should be able to teach. This is particularly tested during question and answers. When you are done taking your history, what is your diagnosis? How would you investigate? You should be able to teach. And your ability to teach is tested in communication. So with that being said, and the previous slide you just read, arm yourself up and let's go. Is that okay?
Yes, Doc.
Yes.
A few ground rules to the newbies amongst us. I take my time to teach. And so, whenever you are lost about something, do not hesitate to stop the class and take me back. If I said something you didn't understand, do not hesitate to stop me and take me back. However, even before you actually stop me, I ask whether everybody understands clearly. Within the time I ask for questions, you should please let me know. If you wait for me to advance in the lecture and you bring me back, I will not go back. It's not I might not go back, I won't go back. So that we don't interrupt, so that we don't just waste time on one thing over and over again, because there are a lot of things we need to know for this exam. Are the ground rules understood?
Yes, please.
Thank you. And so our very first lecture is going to be on cardiovascular medicine. So when we talk of cardiovascular medicine, we are talking of the conditions that affects two systems. This word is actually made up of two roots, cardio and vascular. So when we talk of the cardiac part, I know you know this, but as a recap, we are talking of this part of the system, the heart. When we talk of the vascular part, we are talking of the vessels which connect to the heart, the vessels which send blood away from the heart, and the vessels which carry blood towards the heart. Medicine is actually a branch of the practice that heals diseases without the scalpel. So we have cardiothoracic surgery and cardiovascular medicine. And we have vascular surgery as well. So we are going to study the conditions which are healed without the scalpel. The conditions which affect the heart and then the blood vessels, which are healed without the scalpel. When we treat surgery, we will come back to this same system, but this time looking at conditions which affect the heart and the blood vessels, but would require the use of a scalpel or an invasive procedure. Have I communicated, please?
Yes, sir.
Very good. So we are going to look at the conditions that affect this and then that. Okay, so just before we go there, for example, these are the vessels that actually go into the brain or come from the brain. The red being the cerebral vessels, the blue being the jugular veins. All these are draining the head and neck region. This is the part of the vasculature that feeds the arm or the upper arm, if you will. The red being the subclavian, which continues as the brachial artery, like that, and it goes there. We will look at basic sciences very soon, or you have a video on anatomy, but I'll retreat it. Okay. This is the aorta. This is the inferior vena cava. It goes so everything we are going to look at is centered on this system. we are answering the question, what conditions are treated non-surgically, which can affect the blood vessels and then the heart? Now I begin. In clinical medicine, the way we are taught to diagnose patients is first to speak to the patient, okay? And then after speaking to the patient or after interviewing the patient, what we do is to examine the patient. In examination, we need to take a very closer look at the patient, that is inspection. We need to touch the patient if necessary, that is palpation. We need to drum on certain parts of the patient's body, that is percussion, and we may have to listen with a stethoscope if necessary, that is auscultation. After doing that, we need to order some relevant investigations to arrive at an evidence-based diagnosis. I am telling you how I'm going to approach. I'm not just going to teach you, oh, so we are going to do heart failure, we are going to do myocardial infarction. Then after that, you meet a clinical vignette and you can't even recognize heart failure. When the exam is like that, I saw that and I saw that no, I don't have to give didactic lectures anymore. My training has to be centered on if a 54-year-old man traveled to Mecca and is rushed with a sudden onset of difficulty breathing, which of the following is the most likely diagnosis? My students should be able to add A to B to C and then say that, oh, I saw this and this and this in the question. Okay, so I think it is pulmonary embolism. Someone is rushed with sudden onset abdominal pain, which occurred 3 hours ago. The patient has atrial fibrillation. What is the cause of the abdominal pain? My students should be able to say mesenteric ischemia because he saw atrial fibrillation and sudden onset abdominal pain. So she just underlined, or he just underlined something in the question and he added A to B to C and he saw that this is the diagnosis. What is the next best step? My students should be able to tell me that if I have read the question and I see that the patient has got a PE, then the next or the gold standard is a CTPA. Meanwhile, the possible answers are showing me ECG, CTPA, chest X-ray, maybe echocardiogram. But I synthesized and I saw that this patient most likely has pulmonary embolism. And so I would shade CTPA. I don't need to have recalled it from somewhere. I'm following principles, okay? Good. So the first thing you do in clinical method is to take a history. I'm going to spend time in this 30 minutes to explain to you how questions are set, exam, and then investigations. So you see that in a clinical vignette, they bring a bit of a history. In a clinical vignette, they bring a bit of a history. They may bring a bit of an exam, not all the exam findings. They may bring a bit of investigation. That is how a clinical vignette looks like. And then combine these and then ask you for the next best step or the management or the diagnosis or the pathophysiology or something. But for example, Swalisu, please mute yourself. Hey, mute yourself, Swalisu. For example, if they give you something like, or if I give you something like, a 43-year-old diabetic. Please hold on. A 42-year-old diabetic who is on insulin therapy presents with fever, and a pan-systolic murmur, which radiates to the left axilla. So this is the end of the clinical vignette. With this preamble, I can set a whole lot of questions. I can ask for the diagnosis, or I can ask for the pathophysiology. I can ask for relevant investigations. I can ask for diagnostic signs on exam. I can ask for management. I can ask for complications. Are you following me?
Yes, doc.
Yes, doc.
So how did we tell, or how are you able to tell that this is actually a clinical vignette? It is because you can identify a history, the age of the patient, his comorbidity. All these are histories. This is a sign, an examination sign. So you see that in this clinical vignette, you can see a bit of a history, a physical exam, but no investigation was included. So you see that questions are set based on this. In every question, in every clinical, so far as it's a clinical vignette, you are going to identify portions of the clinical method. And that is my focus. So you see that when I start teaching, I'll first deal with the history used to diagnose. I come to exam, you will see what I'm doing. But with this clinical vignette, I can actually ask a simple question. After this, I can ask a simple question and say, what is the most likely diagnosis? Yes, you can tell me. Okay, hold on. Don't tell me yet. What is the most likely diagnosis? Or I could actually give you this clinical vignette, and then instead I'll ask, which risk factor predisposed him to the underlying condition? Or I could ask you that, which organism is most likely responsible or I could ask you that, which of the following clinical signs will most likely suggest the diagnosis? Do you see how the questions come? Hello?
Yes, please.
Very good. And so, let's see. So, what is the most likely diagnosis? I assume I gave you some possible answers, but I just want you to just pinpoint the diagnosis for me. What diagnosis would you look for to shade?
Could it be infective endocarditis?
Okay. So, another ground rule. Here, I train my students to answer questions very well because I feel if I don't let you start well, when it starts with the OSCE, you might start answering a question in a way that will put the examiner off. Tracy, are you listening to me?
Yes, please.
Please, here, never answer a question with a question.
Yes, please.
So you go straight to the point and don't start with phrases like or clauses like, say, I think, is it, please, I am guessing. Don't do that. Okay?
Yes, please.
When the examiner asks you the question, you go ahead politely. Say, please, it is full stop. If only you are answering the question, it is full stop. Don't answer his question with a question. Don't make him feel like you are guessing, like you've come to play. Don't make him feel like you are not sure and then you are just saying anything for him to actually pick and choose for you. They mark confidence. Class, do you understand me?
Yes.
Yes,
All right.
Doc.
Very good. So Tracy, go ahead. Now answer the question properly. Don't be scared.
I think yes, please.
Don't do I think. No.
Okay.
Sir,
Effective endocarditis. Sir, please, it's effective endocarditis.
That is all. Sir, please, it's infective endocarditis, and then you just keep quiet and then you just watch him.
Okay.
There's no need to talk plenty. Doctor, please, I think, or doctor, please, it is infective endocarditis. Doctor, please, the diagnosis here is infective endocarditis. You don't smile plenty, you don't frown, you talk, you keep quiet. Listen to him for the next question. Okay? So, for the next couple of days, I know that it will take time for that habit to go off. And I might be sarcastic with you a bit. Don't take that to heart. But it's all part of the training. Okay? Good. So, yes, I agree with you. It's infective endocarditis. So this one, are you now going to look at your notes, the didactic lecture on infective endocarditis, or you ought to have been trained to recognize infective endocarditis? You ought to have been trained to recognize pericarditis. You ought to have been trained to recognize biliary atresia. You ought to have been trained to recognize cerebral palsy in pediatrics. That is how the exam is. Okay, so fever plus pansystolic murmur, or fever, a cardiac patient with fever and a murmur in context is infective endocarditis. We'll look at how to pick that in a clinical vignette. But let's move on. Question 2. Which clinical or which risk factor predisposed him to the underlying diagnosed condition? Assuming I had given you a list of possible answers. Maybe A, the age. B, immunosuppression from diabetes. C, the use of IV drugs. And maybe D, his sex. What possible answers? What would you have chosen?
B.
The use of IV
drugs.
So someone is saying immunosuppression. It's actually the use of IV drugs.
Okay.
So, congenital heart disease, recent dental procedures, use of IV drugs, and all that. Do you see? So they can give you a clinical vignette and they can twist the question anyhow they like, and you are still supposed to actually answer the question. So you see that here, the first question is, what is the most likely diagnosis? It might not be the same the next time. Look at question 3. So a 43-year-old diabetic who is on insulin therapy presents with fever and a pansystolic murmur which radiates to the left axilla. Now I'm asking, which organism is most likely responsible for the underlying diagnosis? Now, assuming Tracy had not given us the hint that it is infective endocarditis, it means that the first question the candidate has to answer is, what is the underlying condition? If you can't get the underlying condition, you will not be able to answer the clinical vignette. Hello? Okay, so what or which organism is most likely responsible for the underlying condition? Anybody?
Staphylococcus aureus.
Wow, Staphylococcus aureus. I see. Is that the most common organism in infective endocarditis?
Boss, viridans.
Viridans.
Okay, so now I can see two parties. So all those who are for viridans, give me yeah. Please, nobody should sit on the fence, okay? All those who are for viridans, please give me yeah.
Yeah.
Okay. And all those who are for Staph aureus, give me nay.
Nay.
Okay. So let's hear from the viridans group. The viridans group, why do you think it's viridans?
So, viridans is the most common.
Okay.
Yeah, if the patient abuses IV, that one will cause the streptococcus aureus.
So wait, so are you defending the viridans or you are defending the streptococcus aureus?
No, the viridans, sorry.
So I'm asking, why do you think it's the viridans?
Okay.
It seems your second statement actually made a case for your opponents. Yeah, so I actually those who chose Staph aureus, can I hear your defense?
No, because the Staph aureus is the most common cause for IV abusers.
Exactly.
And this patient is on insulin. So
don't even go on. So you see, the most common cause of infective endocarditis is Streptococcus viridans, or the viridans group is made up of other subspecies. No two ways about it. So you see that MDC will intend, and you see usually the first option is the wrong answer, or is the confusing answer, or is the confusing variable. Quickly they'll write A, Streptococcus viridans. So this one, Charlie, we've seen this a 43-year-old man with a risk factor, presents with fever and pansystolic murmur. Someone who was not ill, who did not have any prior cardiac condition, presents with fever, pansystolic murmur. That's infective endocarditis. Which organism is most likely? Okay, then it's strep viridans. You see it's A, and you see Staph aureus as C, probably. But the candidate is supposed to consider every aspect of the question and answer. Okay, so if you are saying that the risk factor that predisposed him to getting the infective endocarditis is an IV drug, the normal flora on the skin predominantly is Staph aureus, and that actually caused his infective endocarditis. So you skip strep viridans, although it is the most common cause, and start looking for the golden staphylococcus, Staph aureus. Viridans group, have you understood me?
Yes, doc.
All right. So, which of the following clinical signs will most likely suggest the diagnosis? Like I said, the question can actually go up, down, up, down, up, down, up, down. So these are my own questions I just generated now, just to illustrate something for you or to you, and look at how the question just came. This one I've not even brought investigations on, but I have already 4 MCQ questions. So what clinical signs would you look out for when it comes to infective endocarditis? Yes, anybody? Osseous nose. What else?
Janeway lesions.
What else?
Splinter
hemorrhages. What else?
Rot spots.
Exactly. Do you see that? So when you keep doing that, you see that your diagnostic acumen is you understand the question, you know what the question is looking for. Now, assuming I had asked you, what valve will most likely be involved in this infective endocarditis? Assuming I had ended the question here. Assuming I had ended the question, tricuspid valve. Why?
Boss, because it's most the IV drug users.
Exactly. IV drug users, they cause right-sided endocarditis. But the most common valve involved in endocarditis is the mitral valve. I've not started teaching the cardiology. I'm just giving you what I'm going to do, how to recognize these things. I'm not just going to set questions, but I'm going to tell you how to pick up these things in MCQ. So the most commonly involved valve in infective endocarditis is the mitral valve. But if the risk factor is an IV drug user, the veins, he's actually injecting himself, the blood, the veins will carry the organism through the inferior vena cava or the superior vena cava, it will land in the right atrium first. And if there is a diseased valve, let's say the right sided valve is diseased. Let's say all the valves are diseased, but because it's the risk factor is an IV drug user or abuser, the organism is going to land on a right-sided valve. So when it comes to IV drug users, the valves affected are usually right-sided valve. So this question can be twisted. In a patient, can actually make the question simple for you. In a patient who develops right-sided endocarditis or right-sided endocarditis, I beg your pardon, which of the following risk factors will best explain this infective endocarditis? A, recent dental surgery. B, recent prosthetic valve placement. C, IV drug user. D, presence of a congenital heart disease. So you see that the person who understands what the question is looking for, he doesn't mind what options have been presented to him. He's seen IV drug, right-sided endocarditis. It's actually linked to IV drug. So you see, he goes and he shades C, not because he has seen the question before, but because he's been able to recognize what is going on. And that is my objective today. Have I communicated?
Yes, Doc.
Okay.